My name is Anjay Rastogi, and I'm the director of the UCLA Fabry program. Before we get into the slide deck, just a couple of things. April is National Organ Donation Month, so if you haven't signed up, please do so. It's a great gift. And also, April is Fabry's month, so that's why we're doing this webinar today in April. So with that, I'll go over the agenda for today's webinar. Number one, we'll go over what is Fabry disease. I think that's important to know. Number two would be, why should you know if you have Fabry disease? And the last but not the least, if you have Fabry disease, what can you do? But I just want to mention this, what you should know, because Fabry disease is, as we'll be going over some of the data, is underdiagnosed or even undiagnosed at times. So it's very important to be aware of the symptoms and signs. And if you have kidney disease, and this is actually one more point that I want to mention, if you have kidney disease, whether it's just chronic kidney disease, dialysis or transplant, and there is no known diagnosis why you have CKD or chronic kidney disease, then this is really important for you to know. Hypertension by itself should not be listed as a cause, because we don't know if it's a cause of kidney damage or the kidney damage is causing hypertension. So when we go through this, keep an eye out for the signs and symptoms of Fabry disease. So before we get into the symptoms and signs, what is Fabry disease? So Fabry disease belongs to a bigger group of disorders called the lysosomal storage disorders. So in short, we call them LSDs. So what is a lysosome? So this is your normal cell, what we call unaffected cell. This is your nucleus, and these are your lysosomes. And lysosomes, what I call them, are the waste baskets or the garbage crunchers in your kitchen. So what they do is they get rid of all the waste products that we have in the cell. They go to these lysosomes, and in these lysosomes we have enzymes that work at a very acidic pH, and they chop these substances down and break them down and finally get rid of them. Now, if there's problem with these enzymes, for example, there's a mutation that leads to loss of activity or complete loss of the enzyme itself, then these lysosomes cannot break these waste products down, and they eventually accumulate. So the waste basket gets bigger and bigger and bigger. The cell is getting larger, and this eventually will lead to cell dysfunction, tissue dysfunction, and then finally organ dysfunction. So you'll have organ failures. And the organs that are involved is going to be dependent upon which enzyme is involved. So for some enzymes, some organs are more likely to be damaged than others. In Fabry disease, the enzyme that's deficient is called alpha-gal-A, alpha-galactosidase A. So that's the enzyme that's deficient, and kidneys tend to have a lot of this enzyme. So when this enzyme is deficient, kidneys get affected. But this enzyme is also present in a lot of other tissues, including the vascular tissues in your blood vessels. So one of the key manifestations of Fabry disease is vascular disease, and that's a cause of mortality and morbidity in our patients. It's an X-linked disease. So the gene for alpha-gal-A is on the X chromosome, and that's where the mutation happens. Now, one point that I do want to mention about the X chromosome, when we think about X chromosome, we think about males. So the disease that affects males. And the reason for that is because males have one X chromosome, so that's a sex chromosome. So they have one X, females have two X chromosomes. So the thought is that if one is defective, you still have the one normal one. But what's important to keep in mind in Fabry disease, females are also affected, and they can have the entire spectrum from being completely asymptomatic or close to asymptomatic to a full-blown disease as males would have. So the males obviously manifest the disease because they only have one X chromosome, and that's defective, but females can also show. And I think that's really an important point, not just for the patients, but also for the healthcare providers to keep in mind. And when this enzyme is deficient, like I mentioned, there's accumulation of waste products, and the waste product that accumulates in the cells is a glycosphingolipid, and you'll see the term GB3 or GL3. So that basically means is that this is getting accumulated in these lysosomes and eventually will cause the cell to dysfunction and eventually die. How common is Fabry disease? So it's not common. It's actually a pretty rare disease. But what we do think is that it's more common than what the numbers show us, because a lot of the cases are undiagnosed. So if you look at the numbers over here, so first of all, it's a pan-ethnic disease. So there's no ethnicity that is more predisposed to Fabry disease. The reported incidence is anywhere between 1 in 50,000 to 1 in 100,000. But there's also something called the enriched population. So what is the enriched population? Patients with kidney disease are enriched. So the prevalence is much higher in kidney patients. And if they are patients on dialysis, the reported incidence is almost as high as 1% of patients on dialysis might have Fabry disease, 0.5 to 1%. So that's an important population. For the other important point to keep in mind is, for every patient identified with Fabry disease, there are 5 or 6 family members. So this is an inherited cause of kidney failure. It's a familial disease. So it tends to run in families. For every member that we identify, there are 5 family members that have Fabry disease, with the diagnosis or without diagnosis. There's also newborn screening has been going on, and as you can see, it's much higher numbers, 1 in 3,000 or 1 in 1,500. So the key point from this slide is that even though Fabry is a rare disease, it's probably more common than we think it is. And the question is that if you have kidney disease and you don't have a firm diagnosis why you have kidney disease, what's the cause of kidney disease, then Fabry should definitely be on the differential diagnosis. How does Fabry manifest itself? So this is an important point. It's a multi-system disease. So multiple systems are affected, and we'll be going over some of them. The heart is affected, the kidneys are affected, the nervous system, the brain is affected. So it impacts a lot of organs. It's a progressive disease. So over time, and it's sometimes even called a silent disease, but over time it will manifest itself, and then the outcomes are bad. There's, once again, like I said, there's increased mortality and morbidity. And before we had specific treatment, it was not common to see patients live beyond the age of 50. Now, since we know more about the disease, and we have also treatments, patients are living much longer and much more healthier. There's also age-dependent manifestations. So the manifestations that you see in childhood are different from what we see in adolescence and then in the adult life. So and this is why it makes it a bit tricky to identify these patients on just purely based on clinical symptoms. It's a rare disease, like I mentioned. The diagnosis is normally delayed, and sometimes diagnosis is never made. And the average time that we've seen delay in diagnosis is about 10 to 15 years from the onset of symptoms. The disease obviously is present in utero, but the manifestations start in pre-teens or early teens, but there's a delay on an average by 10 to 15 years in making. And one of the key points in management of Fabry disease is early diagnosis, so we can intervene early. So early diagnosis is critical to have good outcomes. And once again, we can see there's also wrong diagnosis. So Fabry is not the first thing that comes to somebody's mind when they see patients with some of the symptoms that I'll be showing. But sometimes it's not even on the differential. So hopefully after this presentation, even as a patient, you can see if you have some of these symptoms, you can go and speak to your nephrologist or your healthcare providers and ask them that is there any chance that I might have Fabry disease. So let's go over some of the manifestations of Fabry. So this is what we call Vertie Salada, corneal. These are opacities in the cornea, which is cornea is the front part of your eye. And this is seen on slit lamp, and you can see these spokes. So this is a whorled or spoked pattern, and this is called Vertie Salada. So this, what's important to keep in mind, this won't impact the vision. So patient won't show up, say that I can't see. But when they go for a slit lamp examination to the eye doctor, they can see this. And if they see this, most of them will actually refer them to a Fabry specialist. But if you have this on your diagnosis when you go and see your eye physician, and you're not being referred to a Fabry specialist, you should actually refer yourself, because every patient who has this finding should be tested for Fabry disease. And it starts early in life, it does not impair vision, and it's on slit lamp. And then on the conjunctiva, you can also see these vessels. So this is the conjunctival findings that we see. But the key thing over here is the Vertie Salada. So if you have these Vertie Saladas, you should definitely be tested for Fabry disease. Then we have something called angiokeratoma. This is a skin finding. Sometimes in layman's language, we also call them a skin rash, but it's not a drug rash or an infectious rash. It's actually something called angiokeratomas based on the pathology. But here, if you see these findings, so these are reddish purple lesions that are not blanchable. What that means is that if you put your pressure on them with your finger, they won't blanch. So these are non-blanchable. And their distribution, they are normally seen in the buttocks, groin, umbilicus, and upper thigh. So what we call the bikini area. So if you don't do a proper examination, you probably might miss them completely. So angiokeratomas are also very classical. They're seen in adolescence or young adulthood. The one historical point about this. So when we talk about why is a disease called Fabry's disease? So Fabry and Anderson were two actually dermatologists who in 1898 independently made the link between these findings and proteinuria, the kidney, when you're spilling protein. So they made the link between the skin findings and kidney disease. And that's why the disease is named after them. It's called Fabry's disease. Sometimes you'll also hear the term Fabry-Anderson. So Anderson was the other dermatologist who made this link. Now, these don't cause symptoms. It's more for cosmetic. But if you see these lesions on your body, you should get tested for Fabry disease. So this is the other reason why to test or look into that if you have Fabry's. Fabry's patients also don't sweat. And how does it? So I always say if you never sweat, it's very difficult to say that I'm not sweating. But the symptoms they present with is heat intolerance. So they can't play out in the warm temperatures, physical activities, and all that stuff. So this is one of the common manifestations, especially in the early part of a patient's life. Pain is also a very significant manifestation of Fabry, especially early on. So there are two ways that this manifests. One is they have numbness, tingling pain in the hand and feet, and this is what acral paresthesias, or they can have whole body pain, which is called crisis. And normally these pain symptoms are brought on by stress. They might have fever, they didn't sleep, or any other stressor in their life, and then these pain symptoms come on. Now, important point over here is that this is a neuropathic pain, so it's coming from nerves. So these classes of drugs like ibuprofen, Motrin, the NSAIDs, by the way, I did a webinar on this a few months ago. You should definitely check it out. It's on medications and kidney disease. But there's a class of drug called non-steroidals that includes all the over-the-counter, most of the over-the-counter pain medications except Tylenol. They are not good for your kidneys, blood pressure, heart, so you should avoid them. But especially in this condition, Fabry disease, first of all, they won't even be helpful because most of this pain is coming from neuropathic pain. So it's a different kind of pain medication that you need. In our program, we refer them to pain specialists. So if there are non-pharmacological methods of controlling pain, then I think that would be very helpful. But after a point, this actually should be dealt with. And this is once again going back to the Fabry's program, the multidisciplinary team that I'll be going over in the management. So pain. Then the GI symptoms. So GI symptoms also are very significant, especially in the adolescents. And some of them are constipation, diarrhea, bloating, they feel full. And a lot of times these patients are misdiagnosed as having irritable bowel syndrome. So if going back to your childhood or early adolescence and you had these symptoms, then think about Fabry's disease as well, then getting tested for that. Cardiovascular disease. So this is very important. This comes in middle ages, very, very important. I mentioned the alpha-Gal A enzyme is in vascular tissue and heart. So its deficiency causes vascular disease and heart problems and causes enlargement of heart, especially of the one chamber of the heart called the left ventricle. So if you see something called left ventricular hypertrophy, LVH, and it's out of proportion, kidney patients tend to have LVH, especially with advanced kidney disease, and that's because of high blood pressure, anemia, fluid overload. But if you have LVH out of proportion to kidney disease, then your healthcare provider should think about Fabry's disease. So that's really important. Fabry disease also leads to rhythm problems. They lead to a lot of arrhythmias. And this is also something that will need to be addressed by, and for this we actually send them to not just to a cardiologist, but to a subspecialty within cardiology, and these are called the electrophysiologists. So we normally try to send them to our cardiology colleagues they can do echoes, they can do rhythm studies, they can do cardiac MRIs, all the tests that they will need to assess the progression of disease. And some of these patients, they do progress to heart failure, and they might need a heart transplant. There have been patients who actually had a heart transplant and they still didn't know that they had Fabry disease till the very end. So these are some things, once again, to be proactive as a patient, that do you have Fabry disease. Kidneys are affected. Once again, they're affected early on, but they start manifesting probably in the late teens, early 20s. They spilling of protein is an early sign. So once again, I did a webinar on kidney disease. You should definitely go and check it out. I go over proteinuria, I go over EGFR, and how to test for kidney disease. So all those things would be. Now, if the patients are not treated, most of them will end up on dialysis by the 40s or 50s. And I think this is important for, number one, the Fabry patients in general don't tend to do well on dialysis because this is a vascular disease, just like diabetic patients. So that's number one. Number two is if they're going for a transplant, especially if it's coming from one of their relatives, they have to be very careful, because that if they have an undiagnosed Fabry disease and their family member donates it and they have Fabry disease, then actually it hurts both. It hurts the donor and hurts the recipient as well. And that has happened actually, in which a patient in which they were not suspecting Fabry disease got a transplant from one of their relatives, and when they did a biopsy on the recipient, they found out there was Fabry disease. So once again, it's very important to know if you have Fabry disease, even if you're on dialysis or transplanted. And like I said, please watch the previous webinar. The role of a nephrologist. So the nephrologist has a very key and central role in Fabry disease, because if the patients, they at some point, they will cross paths with the nephrologist. The question is that, will the diagnosis of Fabry be made? So I think the nephrologists have a central role, and they have to keep their eyes and ears open to that when they see a patient in which they don't have a diagnosis of any cause of kidney disease, and they call it unclear etiology, then can this patient have Fabry disease? And I think that's something important. This is just protein in the urine. Like I mentioned, we need to check if they're spilling protein, and as the kidney disease advances, the kidneys become small and shrunken, and finally they stop working. And they might need dialysis. There could be hemodialysis, there could be peritoneal dialysis. Peritoneal dialysis makes a bit more sense because it does not involve the vascular system, but the best treatment if the patient has advanced kidney disease is transplantation. Now, there's a lot of neurological manifestations of Fabry as well. I already mentioned neuropathic pain, but stroke and what we call TIAs, transient ischemic attacks, are fairly common in our patients. And the term that I used over here is cryptogenic stroke. So what does cryptogenic stroke mean? That means that if there is no known cause for this stroke. So once again, they're idiopathic or the cause is not known. So if you have a young individual who had a stroke and the cause is not known, then Fabry definitely should be on the differential. They can have numbness and tingling, they can have hearing loss, especially at advanced ages, ringing in the ears, and then also they have something called white matter lesions, WMLs. And these white matter lesions are seen in multiple sclerosis as well. So some of these patients have been misdiagnosed as multiple sclerosis. So that's something also to keep in the back of your mind. So identifying these patients is not easy. As you can see, there's a whole bunch of manifestations, and there are a lot of more common causes of these manifestations. So Fabry does not come as a first diagnosis or jumps. So, and also it's over time. So they're manifest different when you're a child, adolescent, and adult. So a lot of things get lost in translation. So it's very important that patients stay involved in their own care and keep a good history. A lot of these symptoms disappear in adulthood. You don't have sometimes pain, the GI symptoms get better. So unless you dig deep into your past, you might not tell your physician that you had all those symptoms. But as a patient, it's very important to keep a detailed history and tell your physician that I have these symptoms. And if you think that you might have Fabry's, then you can even contact our program. I'll give you our contact information at UCLA Fabry's. It's difficult to identify a patient with Fabry's, but it's easy to diagnose. And the diagnosis is very simple. It's a simple blood test. That's all that you need. And what we do is the enzyme activity. So I mentioned the enzyme that's deficient is alpha-Gal A, alpha-galactosidase. So we check for enzyme activity and we check for the gene mutation. So in the females, we have to check the gene mutation because the enzyme activities can be within normal limits because they have one quote-unquote normal X chromosome. But in most of the males, the enzyme activity should cleanse the diagnosis, but we still do the gene analysis, especially in the first one. So like I said, I want to stress it's difficult to identify these patients, but once you've identified patients at risk, it's easy to diagnose. What are the common misdiagnoses? The patients have been, and this is just a very short list, but they've been rheumatoid arthritis, multiple sclerosis, irritable bowel syndrome, growing pains, malingering, the list goes on and on and on. So there are a lot of, so once again, there's a bit of delay in diagnosis. And that is if the diagnosis is even made. A lot of these patients are never. So when should you suspect Fabry's? When should you think that I might have Fabry disease? So one is if you have chronic kidney disease of unknown cause. So if you have kidney disease, whatever spectrum, early, late, dialysis, transplant, but you never knew what caused kidney disease in the first place, think about Fabry's disease. I think it's very, very, and it's not just for you. First of all, even though you might have a transplant, your other organs are still at risk. So those need to be taken care of. We spoke about the heart, we spoke about the brain, so all those things. But also your family members. For every Fabry patient that's identified, there are 5 or 6 family members who are also identified with Fabry disease. So it's difficult to identify patients, but if you have family members, it's important to talk to a geneticist and get a family tree, see the patients who are at risk, and the family members who are at risk should be tested. So not everybody has to be tested. Based on the way the X chromosome goes from one generation to the other generation, you'll identify patients who are at risk, and the patients who are at risk should definitely be tested by a simple blood test. The corneal Vertie Salada. So if you have these Vertie Salada findings, you should be tested. If you have angiokeratomas, you should be tested. Left ventricular hypertrophy, cryptogenic stroke, or any of the other clinical manifestations that I mentioned, if you think they're not making any sense, get tested for Fabry's, because like I said, that the testing part is relatively straightforward and simple. It's a simple blood test that you have to do. So you've identified the patient, you have diagnosed the patient. Now, how do you manage? So manage we have a multidisciplinary team at UCLA that takes care of these patients. So the key thing in management is early diagnosis, because it's a progressive disease, and the earlier you diagnose, the earlier you can treat the patient and follow them. So key thing is that diagnosing early. Once again, a multidisciplinary team. I'll go over this team in a bit more detail. At-risk family members should be tested. And once you have a diagnosis of Fabry disease, we have scheduled assessments. So at the time of diagnosis, 6 months, 12 months, 2 years, 3 years, we have a whole list. And this should be done on a routine basis. It's basically, should be on your calendar that in 6 months I'll get this. And then you talk to your multidisciplinary team and see how things are progressing or not progressing. The multidisciplinary team, this is the basic team. You need to have a nephrologist, a cardiologist, a neurologist, a geneticist. So these are key point. And then a pain specialist and a primary care physician. So this forms, and then whatever other problems you have, you can have an extended team. But this is what I call the core team that takes care of my Fabry's patient. So how do you manage Fabry's disease? So one is the enzyme is deficient, you give the enzyme back. And we have the enzyme available in the US called Fabrazyme, which is a recombinant enzyme available since the early 2000s. And that can be given to the patient. It's an infusion, it's given every 2 weeks. Now there's another drug that came out just recently. We call this chaperone therapy. It's an oral agent. It's for specific mutations. So if you have a specific kind of mutation, you should ask your healthcare provider that would you be actually eligible for this medication. And then, like I said, regular meetings with your multidisciplinary team is very important. This is the enzyme that I spoke about. The one that's available in the US is Fabrazyme. So with that, I think I've covered about Fabry disease. I just want to give our contact information. If you have any questions, please contact us. This is our phone number. This is our core kidney email, but we also have one for Fabry disease. And also do visit our website, the core kidney website at UCLA Health. And finally, last but not the least, we'll have a very entertaining and educational kidney fair, our 4th annual kidney fair at Santa Monica Beach. And Fabry disease will be discussed at this fair, but also we'll discuss a lot more. It's all about healthy living. And the focus is going to be, once again, on education, but also entertainment fun. So with that, thank you very much for attending this webinar. And once again, if there's any questions, please feel free to contact us. And hopefully I'll see you at the kidney fair. Thank you very much.